And yep, done. Got it.
All right.
Fantastic.
Thank you. Sorry. Um, all right. Yeah. So I will begin by taking everybody through some housekeeping rules and the background of the project. And this will be followed by my colleague sharing the findings of the study. Finally, we will invite reflections from some members of the research team, advisory board, and participants in the study. And after that, we'll have an open Q&A. So that's largely how this discussion will be structured. On to the housekeeping announcements. So the webinar will be in English and we will finish in 1.5 hours, most likely lesser than that. I will request everyone to keep their mics switched off if you are not speaking. You can choose to keep your cameras on or off based on your preference. I would request everybody to change their Zoom names to their names, and if you're comfortable, your pronouns as well. Um, uh, yeah, towards the end, we'll have a Q&A session. So you can continuously through the session put questions in the chat. And towards the end, of course, you can use the raise hand function and unmute yourself and ask questions as well, whatever you prefer. Some parts of the presentation may be distressing, triggering. Feel free to step out at any time that you need. The trigger warnings are for mental health problems, dysphoria, violence, stigma, economic precarity. We will be recording the webinar and uploading it to YouTube for public viewing. We will also take a picture of the attendees towards the end. So in case you would not like your picture, screenshots of the Zoom shared on social media, you can let us know and we'll make sure your identifiers are blurred. You can DM me personally. Finally, I'm sincerely grateful for everybody who has joined us today. So grab whatever you need, water, chai, a notepad, or anything that you might need. And I will get started. So the TransMH project is hosted at Sangat, and Sangat is a 28-year-old nonprofit that has been at the forefront of public health innovation and research in India. Some areas of work that have been child development, addictions, youth mental health, and task shifting approaches. And in Madhya Pradesh, our work spans over 12 years, and we have a dedicated hub at Bhopal as well. We closely work with the state health department to develop and implement interventions. Currently, Sangat is running 20 projects across 5 districts in Madhya Pradesh, also in Gujarat, and also projects that are more national in scope. These projects address critical areas such as mental health, digital mental health, implementation science, health equity, and trans health, research ethics, and capacity building. This particular project is hosted at the Initiative for Health Equity Advocacy Research at Sangat. Slightly divergent in focus, iHEAR started in 2020, drawing on lived experiences of Dr. Aksa Sheikh and Satyendra Singh, specifically with respect to marginalization of trans and disabled people within health systems. Early in our work, we realized the value of participatory approaches, which has since become our key tenet, in line with the motto, nothing about us without us. Currently, we have 3 areas of focus that are brought to life by an exceptionally talented and dedicated and diverse team. The 3 areas of work start with participatory research on health access and the experiences of the LGBTQIA+ community and the disability communities. Currently, there's a project called TransNet that is looking at technology-facilitated violence experienced by the trans community, and another research project called Access Matters, looking at how hospitals in Madhya Pradesh and Goa, how friendly they are for people with disabilities, including people with invisible disabilities. Recognizing that health professionals are a key agent of change within the space of health equity, we work with medical education that has a history of being queer, transphobic, and ableist. Through our projects, we aim to understand what competencies and skills are required by health professionals to provide affirming care and how these can be taught. Currently, one project is looking at how art can be used to teach some of these competencies to provide more affirming care. Finally, we also focus on building and strengthening capacities for community members and allies to do ethical and participatory research and advocacy. Through community engagement, media engagement, policy engagement, and academic engagement, we hope to work towards equity through an intersectional and participatory lens and go beyond academic papers to affect real change. These are some of our funders and collaborators. So with this context, I would like to share the background for the TransMHPrep project. So I've given you a little context about iHEAR. So the first project within iHEAR was a project called TransCare COVID-19, which was a qualitative study aimed at understanding the experiences of trans and gender diverse people during the COVID-19 pandemic. The study challenged the notion that the pandemic was an equalizer, or now we are all in the same boat, and revealed that for the trans community, there were devastating and intersectional impacts of the pandemic on their mental health in the context of social isolation, disrupted health and social support access, income, housing and food insecurity, experiences of violence, etc. Literature shows that there was an increase in experiences of anxiety, depression, suicidal ideation, dysphoria, substance use problems, grief, death anxiety within the community during this time. Systemic barriers were experienced in healthcare access. For instance, healthcare access is one of the key domains, and people experience a lot of anticipated stigma, transphobia, misgendering, and denial of services. I'll share on each of the slides, there'll be some quotes, and these are from that first study that I'm talking about, TransCare COVID-19. So in the first quote, a trans woman is saying that I was so anxious of how I'm going to be treated as a trans woman. And another gender fluid person says, every time I'm unwell, it's not about physical unwellness that I go through, but also emotional and mental trauma of being neglected and ignored. So in this context, they're talking about their experiences within the health system, where the barrier to entry starts with even the motivating oneself to go to the health facilities. Another challenge that was brought up was in accessing mental health care, and this was worsened by stigma and precarious employment and lack of legal and social support. The quote here is from a non-binary person, and they say, I couldn't go to the hospital for therapy, and online therapy just didn't work for me. Plus, it was getting a little hard to afford it myself as I don't have a job, and so I just discontinued that. The next factor that came up recurrently was disruption of chosen family and kinship networks due to the lockdown, and also being in hostile family environments, in natal families or due to intimate partner violence that increased the mental distress for many in the TGD community. So the quote is, queer people particularly need to be connected with others in the community. Therefore, the pandemic and the lockdown particularly affected the queer community. Often, conversations about gender identity came up when you were stuck at home with the family. For example, even things like, when are you going to get married? Your freedom to speak to others freely becomes limited. This is a non-binary person again. And one of the last factors that I'll mention here, but there are lots of other factors, are restricted access to gender-affirming care, like HRT, also increased dysphoria. And in the quote, a transgender woman is talking about how she had to stop taking HRT, and that increased her dysphoria, and she was already experiencing COVID, and that also took a toll on her. So when you are having COVID, you are advised not to take HRT for a month. So for 1 month, I had to stop that, which meant a lot of mental issues for me. I was having dysphoria during the time when you are suffering from COVID, which was very difficult for me. That added to my anxiety. Thus, the vulnerability of TGD persons during the pandemic and a gap in trans-inclusive responses during the pandemic gave way to this project. From our own knowledge and lived experiences, so much of the support that was provided to the community was by the community through mutual aid, civil society organizations, queer trans health professionals. And we wanted to take stock of these experiences, learn from them, and prepare for the future. Thus, the TransMHPrep project aimed to understand and document experiences of MHPs and CSOs in providing mental health support for trans and gender diverse people during the COVID-19 pandemic, and use this to inform best practices to ensure mental health related pandemic preparedness for TGD persons. Since we had already spoken to the communities about their experiences in this project, like in the previous project, the COVID-19 project, we wanted to focus on support providers and understand what are the forms of mental health support that were being provided during this time. What were the challenges that they faced in providing this support? um, what were the solutions that they recommend, and what are the competencies that they think they should know, competencies and skills that they should know to be prepared for future public health emergencies. In the next slide, we have our team. They bring a lot of lived experience and subject matter expertise. We have Anant, Aksa, Gautam, Hari, Parth, and I. Um, um, Another key part of our project was the Community Advisory Board. This consists of MHPs and peer support providers that work with or are from the community. Here we have Aritra, Aryan, Busena, Dr. Bala, KP, Ne, Pooja, and Tanvi. Um, Truly, honestly speaking, their input has been really crucial to completing the project. The research team and advisory board were a few ways in which community members were involved throughout the lifespan of the project. Another way was through a consultation that we conducted in October in Mumbai to get feedback on the draft of the best practices that we had created. Through these meetings, the design, analysis, recruitment, and dissemination of the study were iteratively evolving with input from community members and MHPs. The next slide is a quick summary of the process. We started by taking 18 interviews of MHPs, peer support providers, CSO representatives. We used this data to develop draft one of the best practices, which was then used to get feedback on in the consultation in Mumbai, which informed the final draft of the best practices in addition to a couple of more interviews that we took. And finally, we developed the draft 2 and are now in the process of disseminating the findings. This webinar is one way of disseminating the findings back to the community and all the stakeholders that were involved in the project. So we're really excited that we've reached this stage. Finally, talking about analysis, how we analyzed all of the interviews that we took. So we use something called a framework analysis to inform the best practices document and some of the findings that we'll share today. The process began with us transcribing the interviews and familiarizing ourselves with it. Then 3 researchers independently coded a couple of transcripts, and then we came back together and we discussed the ways in which we coded similarly and differently and developed some kind of consensus on how we want to code going forward. Then Parth used this consensus frame to code the rest of the transcripts, and these codes we used to develop a coding matrix. And then and a coding matrix is just a table with 2 axes that allow us to organize the data. And then finally, we use this table to summarize and interpret the findings in a way that is both comprehensive and actionable. Excel was something that we used. We didn't use a software, used Excel. I mean, Excel is a software, but like a specific data analysis software to streamline and structure the analysis. I will now stop speaking, and I would like to invite Parth to share the findings of the study.
Thank you so much, Sharon. Very excited to see so many people here. Hi, everyone. My name is Parth. My pronouns are he, they. I'm the research assistant on this project. I'm a queer non-binary person and a mental health professional by training. And I'm very excited to talk to you a little bit more about the findings of this particular project as well. So when we spoke to you about a little bit about, how we didn't want to go back to the community members and we wanted to go to service providers, essentially to not re-traumatize the community members into narrating the experience of the pandemic all over again. What was so interesting about this particular study was that even though it was done in a very short amount of time, we did this over this entire year, that out of these 20 interviews, a significant amount of the participant pool were participants who identified either as a part of the trans and gender diverse community or as a part of the larger queer community here in India as well. And something that was very helpful here was that not only were they bringing in their lived experiences of being from the community, but they were also bringing in their learned labored experiences of working during that time and providing psychosocial support. When we look at the locations of the participants, it is very interesting because that time, we all remember that time with the pandemic, there were some restrictions which were lifted off. At some times, there was access to transportation and mobility, while sometimes there was not. A lot of the participants were working out of metropolitan cities in the following states like Delhi, Tamil Nadu, Karnataka, West Bengal, Uttar Pradesh, whereas a lot of them were also at the same time working hybrid, where they were working either in person or they were working pan-India, coordinating emergency relief and other support measures as well. Out of the 20 people that we interviewed in great depth and got to know a lot about their stories, a lot about the experiences navigating the pandemic, the challenges that they faced, we had 6 counseling psychologists, 2 clinical psychologists, 1 psychiatric nurse, 2 psychiatrists, 3 peer support providers, 5 CSO representatives, and 1 lawyer. It is also very important to note that a lot of people here, these are the professional designations that they brought through their learned and lived experience. However, a lot of them were also involved in peer-to-peer support and emergency relief happening within their own community or grassroots settings as well. So these are not set in stone by any measure. In terms of the work experience, it is very interesting to note that 35% of our participants out of the 20 people just started out their career during the pandemic. These were people who had 0 to 5 years of experience. Either they just graduated or were in their training to be clinical psychologists, or in their training to be psychiatrists, which is doing their internships at that point. And at the same time, there were people who had 6 to 10 years of experience, who were pretty well established in a form of providing psychosocial support, with 30% of our participants having more than 10 years of expertise within the field as well. When we look at the mode of providing psychosocial support, it gets very interesting because what do you qualify as purely online and in person when you're working in a tertiary care center or when you're working in a primary health center, right? Here, when we look at the major chunk of the work done by the psychosocial support providers who took part in the study, 30% of them worked in person. This was either in primary health centers, in trusts, in different community organizations or health organizations, or they were doing door-to-door emergency relief, whereas 55% of them worked online. So this was peer support provision, which was online. This was telemedicine, which was online, or telepsychotherapy, which was done online. 15% of them worked in a rotation. So they worked out of their inpatient or in-service user spaces and also went back to the telehealth spaces and were doing those things simultaneously as well. We're talking a little bit here about the age as well, because we were very interested in the intersection of different social locations that our participants brought, right? There were some people who had just started out their career, and there were some people who had 10 plus years of experience working in this particular field as well. So what was so interesting for us to note was that a majority of our participant sample was between the ages of 31 to 40. And there was a significant amount of sample which was also between 20 to 30. These are the people who just started out their career. I myself started out my career during the pandemic itself as a mental health professional. So it was good to know what were some of the challenges that people faced right at the onset of their career versus what were some of the things that they had to adapt with while they were moving spaces, adapting to the pandemic, and also shifting the way that they were providing care. What did we do with all of the data that we got? One, that something I absolutely love about qualitative research is that you get such rich narratives out of their experiences. Something that we do here at iHEAR and at Sangat as well is that we don't want to limit this to just academic results. So what we took was we took all the data that we got, all the narratives, all the lived experience of our psychosocial support providers, and formed a policy brief specific to mental health professionals, mental health institutions, and people providing psychosocial support. So what I'm going to be presenting to you now is one of those outputs that we have created amongst many that we're working on. These are recommendations for trans and gender diverse affirmative mental health and psychosocial support during public health emergencies. What we've done is we showed one version of the best practices during the consultation event. People from the community, different stakeholders, we scrutinized, reviewed, refined those best practices. And then we went back to the whiteboard. We said, okay, now what can we do with those? What can we do with the new additions? We interviewed a few more people. We also presented this to our community advisory board throughout the year, and then created this particular policy brief. The pandemic, like Shan was speaking about during the earlier study, what came up in this study as well was that the pandemic posed significant challenges for the trans and gender diverse community. A lot of people lost their livelihoods, people faced food and housing crisis. There were threats and harm from the families that they were living with. Lockdown had cut a lot of people off from the support systems. It harmed the community's physical and mental well-being, which was something that the community members, mental health professionals, community-based organizations were all left unprepared for. And a lot of people and a lot of communities specifically still feel the effects of the pandemic even today. So one question that comes up a lot is why are we talking about the pandemic 5 years in, right? What is the point of doing this right now? And what is the point of focusing on the trans and gender diverse community? Something that we wanted to highlight and spotlight was that a lot of community members still feel the disenfranchisement from the pandemic and the consequences of the pandemic as well. I'm going to be presenting to you these 25 recommendations under 5 themes with some lived experiences and quotes of the participants. But what I want you to focus on while you read these quotes and while I speak about these quotes as well is to place yourself again during the pandemic if you're comfortable, but also to reflect at what the service providers were talking about and their experiences of having to navigate a pandemic on their own while also working as frontline workers in many cases. The first theme that we identified for mental health professionals and competencies and recommendations required was strengthening mental health service delivery during public health emergencies, because that was something that not everyone was prepared for. There were no protocols, so it was a very hands-on trial and error thing that a lot of people did. Here, I'm going to be quoting an example, a quote from participant 15 from the project, who is a clinical psychologist who was training to be a clinical psychologist at that point and described herself as a woman of trans experience. She said, and I quote, I was working mostly in a low resource setting. We also had long periods of halt in our services because we really did not know how things were going to go. The whole department, like the whole batch of trainees at one point during the early times of the pandemic, we all got infected with COVID. And as a woman of trans experience who was transitioning during that time, it was very, it was like walking down uncharted waters because I did not have a single example before me on how to navigate this. Not only was this participant training to be a clinical psychologist, providing mental health support, but was also transitioning at that point during a public health emergency. Through similar experiences from our participants and also from the narratives of the community, we created 6 recommendations under this particular theme of strengthening mental health service delivery. These involve providing pro bono and low-cost services with flexible schedules, strengthening existing telehealth services to expand the access to mental health in remote and underserved areas, to incorporate non-traditional therapeutic methods, and to explore alternate mediums of care such as phone and text-based support. Now, a lot of people are already practicing this today. But what came out from the narratives of the pandemic was that not everyone has access to internet, and that access to internet in itself is a very privileged space. But the moment you have access to internet, you're living in a family which is not supportive of your gender and sexual identity. If you're even able to access mental health support, can you switch on a camera? Can you be in a therapy one-to-one session for 45 minutes or an hour? So what a lot of practitioners did at that point, they started working through phone and text-based support. They started using art-based mechanisms, non-traditional therapeutic methods that are not part of the day-to-day clinical work, which help them not only connect with the community, but also find and provide care in the most best way possible. There was another recommendation from our participants to implement inclusive approaches in telesupport, which means working through a gender-neutral language in the intake form, showing symbols from the community in your virtual background, symbols, etc. One thing was also so interesting was that a lot of people realized that in real time, when there were COVID wards, there were no spaces for transgender people or gender diverse people. So to set up trans affirmative support in primary and tertiary care settings, this includes gender neutral registration, separate wards for people from the community, wards for inpatient care, and also inclusive washrooms. None of this would be possible if we don't speak about sensitization sessions for not just the medical professionals, but for a larger community who's the support staff in these organizations, in these health centers, right? So one of the recommendations that we also wanted to provide here was to conduct these sensitization sessions in primary and tertiary care centers, disaster relief camps, care home for elderly people, correction facilities, wherever there are transgender individuals, so that everyone, right from the person at the reception to the healthcare provider or the support provider, are sensitized to the needs of the community as well. Another comment here I want to bring in is of a clinical psychologist who was a cis-het woman who spoke about the fact that she was working in the trust and also training at that point, navigating the pandemic herself. She said, and I quote, a client from the Hijra community would wear a Mangal Sutra and come to the session. And I had to sensitize the people who would call out the client's names and would take the appointments. It's a long way from the main gate. There's a passage that they need to come from, and then there's my cabin. A lot of people sat in the waiting area. And I think that's why I felt I need to sensitize the support staff for the TGT community. It was so interesting to hear this participants' narratives of not only working in an inpatient setup during that time, but also navigating the pandemic herself, where she spoke about how sometimes there would be 7 to 8 sessions in the outpatient system and then inpatient units. So the support staff would also get frustrated when people are wearing masks and giving support in PPE kits, where it became essential to provide sensitization so that the people from the community who are sitting in the waiting area don't get discriminated against. The second theme that came up very frequently from our conversations, not only through these interviews, but also the community consultation event, was the fact that there was a lot of crisis management that the service providers had to do at that point. This was not just mental health professionals, but also people from the legal aid, CSO representatives were part of these different crisis management programs and outreach. One quote that I'm going to read out here is of a CSO representative who's also a community member. He said, and I quote, "A lot of queer people and gender diverse individuals lost their access to social support. There was a pandemic outside, and then there was turmoil inside. So what we did at that point was we established mental health services because this came up as a very frequent need. People often calling the helpline and going, I have no one to talk to, I'm feeling scared, I'm feeling alone, I'm feeling desperate. And when people have lost their jobs, and people have lost their incomes. So what this person from the CSO did, they identified a lot of helplines that people could reach out to and call. They identified psychologists and psychiatrists, empaneled them, and then created an internal referral system where people who were operating the helplines would be able to refer people from the community to a specialist care provider, and also remunerated the mental health professionals providing the support at that point. Crisis management and community-based interventions were very frequently coming up during these interviews. So we recommend 4 primary things here. One is for mental health professionals to work with civil society organizations and community-based organizations to provide emergency relief, evacuation support, and temporary residence for community members. A lot of people from the study spoke about the fact that their role did not just stop at providing support during that 1-hour session that they were taking with the community members or the clients, but they all actively started doing referrals and outreach, etc., to make sure that the community is safe or the members from the community are safe that they're working with. The second was to train in trauma-informed crisis intervention methods for service provision. What we also noticed from the interviews was that a lot of people providing online support, teletherapy, telemedicine, telecounseling, they did not have ample measures or were not adequately trained to provide immediate crisis support at that point. It becomes a very difficult thing for the service providers themselves who are also navigating the pandemic. At the same time, they feel helpless when they see a community member at risk. Connecting to this, we also spoke about the fact that it's very important to develop referral systems to ensure legal and specialist support providers are present for the community. This doesn't just limit itself to lawyers, but also to gender affirming services, specialists like gynecologists, endocrinologists, primary care physicians, etc. We saw a quote from the earlier study where someone spoke about the fact that you can't take HRT for a while when you have COVID. This was also something that a lot of peer support providers themselves were getting questions with as to what do you do when you are accessing on your HIV medication, you're taking HRT, or you're going through a surgery, or you have a surgery planned in the future. What do you do when you're not in loop with any specialist and you've been isolated from that space as well? We also spoke about how there was community-led initiatives that were coming up, that a lot of people were running online support groups, communities, which were not necessarily therapeutic, but had elements of support, social support embedded within them. And that becomes extremely important to promote such interventions moving forward in public health emergencies as well. We had a significant amount of participant sample, 3 people who only provided peer support, but there were nearly 5 people who worked within their own roles as mental health professionals, CSO representatives, and also provided peer support at that time. One quote I'm going to be reading out is from a non-binary peer support provider that said, a lot of community members would come to the peer support and say, hey, I'm actually struggling because I can't access my HRT anymore, or I'm in the process of getting a gender dysphoria certificate. Or I don't know if I should go ahead with the top surgery because there's so many other health complications to think about, and I don't know who to turn to for advice. End quote. Because we'll be able to give them the space to process their emotions, but that can only help to a certain extent. And unless the material circumstances change, it's very possible that the distress that the community member is going through is going to remain the same. This was something which was echoed by a lot of different participants as well. The fact that people coming in for peer support, and there's only so much you can do when you're providing online support. Which is why we came up with these 4 recommendations for mental health professionals. 1, to provide formal training to peer support professionals and to set clear expectations of what peer support provision entails to ensure that there is some effective assistance that can be provided. Second, to supervise peer support providers in administering psychological first aid. Not every person from the community member had access to mental health support or specialist support. Those who did were again detached from mental health providers and were located within the community. So what we're recommending here is that peer support providers can administer psychological first aid as an immediate crisis intervention at a grassroots level. However, they require continuous and regular supervision by mental health professionals to make sure that they themselves are safe and are providing this in the most ethical format. Another recommendation was to explore alternate methods of care Here again, this is text-based support to effectively engage with the context of the community. There were a lot of people that spoke about the fact that they would join online circles, which was easier to join those on Zoom with their camera off or their microphone off and just hear other people from the community talk, because that's the only level of support that they could offer, which is not something you would see in traditional mental health support or peer support as well. We also emphasize a lot on understanding the limitations of peer support. The onus of care should not always fall on the people from the community who are also taking on the role of peer support. Every person who provided peer support within this participant sample did this on a voluntary basis. They were doing this either in an informal way by connecting with people in their own community or through formalized peer support mechanisms as well. However, we emphasize that there are limitations of peer support and that it's very important to create referral systems with specialized care providers, including but not limited to mental health care as well. Who does this and how does all of this happen? One thing that when we were also working on understanding these recommendations and best practices, we went back to the community consultation event and spoke to the community members as to where does the onus lie and who needs to do this and how can we make this move forward as well. Something that came up was that there is a need to have recurrent capacity building and professional development of mental health providers. Because mental health has a history of being very coercive, ableist, transphobic, queerphobic, it is only natural that there is a distrust which is placed by the community members in mental health professionals as well, which is something that came up from the study as well, where people noted that was very difficult for community members to access mental health support and then also trust the professionals at the get-go. Here, I'm going to be reading out a narrative from a peer support provider who also worked as a CSO representative, where they said that in instances of conversion therapy in inpatient centers, the family is not ready to give any information about the community member held against their consent. And then what can I do? We go to the police and the police say, go to a mental health place or go to the home or the hospital or anything else but a police station. So we just have the information about a community member at risk and we're not able to do something. This was such a jarring interview when I was sitting in this interview and we were talking to the peer support provider. It was such a jarring narrative because not only is conversion therapy banned, but it is a very regular norm in a lot of different tertiary care centers and where people from the community go through psychiatric incarceration and conversion therapy. So what do you do in that case? There is a public health emergency which is taking place. There are already lockdown measures across the country. It's difficult to travel as a support provider doing emergency relief. The moment you hear about a community member who's held against their consent, you go to the family to ask about information, but the family who doesn't recognize that as an issue doesn't want to give you any information. So what do? You go to the police, but then the police says this is not urgent enough because there's a pandemic going on and there's a lockdown going on. What do you do then? So it becomes extremely important to develop the capacity and professional development of not just mental health professionals, but professionals across the board that interact with the community recurrently. Here, we are first recommending mental health professionals and others to establish peer supervision and learning circles to train in queer and trans affirmative care, recognizing the fact that this is not a norm in India yet in the education curriculum that is there to train mental health professionals. To second, center the lived experiences of the community members during care provision and work with a systemic, intersectional, and culturally sensitive lens, which recognizes the harm that this field has already caused the community members and do not pathologize the experiences further. Third, to collaborate with community-based organizations to reach and engage with community members in remote and underserved areas. A lot of the people that we spoke to worked and operated out of metropolitan cities, though they had emergency relief programs deep into remote and underserved areas where it was very difficult for them to reach. So they had a recurrent thought that what can we do and how can we reach these community members effectively? Fourth, and I think this is something which came up very recurrently, was to engage with legal aid providers. A lot of mental health professionals do not undergo training, which talks about the relevant laws and policies which are there to safeguard the trans and gender diverse community. So something of the recommendation was for people in the mental health space, mental health institutions, to constantly work with legal aid providers to be updated on what are the rules and norms, to also refer the community members to a lawyer, to a CSO representative, to an organization that can support them legally. Fifth would be to actively create spaces in primary health centers for underrepresented cultural identities. Here, when we're talking about trans and gender diverse, we are very cognizant of the fact that trans in India doesn't just limit to people who are transgender or people who are non-binary, gender fluid. There are cultural identities which often go multiple marginalization or go through underrepresentation in public health in primary healthcare settings. These are people from the Hijra community, the Kinna community, the Arawani community, and the Jokta community as well. At the same time, we also recognize there are a lot of people from the TGT community that have multiple marginalizations. These are people with disabilities, people from the Dalit, Bahujan, Adivasi communities, elderly, transgender, and gender diverse people, people engaged in sex work, and people living with HIV. So it becomes extremely important for mental health professionals to continue their professional development and learn how to engage with these intersections with the community members. One thing to note here is that we added peer learning with continued professional development, recognizing the fact that CPD and access to CPD courses and finances for CPD courses is not something which every mental health professional today in India has. Therefore, these things can also be learned through peer learning, which a lot of our participants did during the pandemic themselves. The fifth, and I think something which resonated with me the most, being from the community and also being a mental health professional, was ensuring care and well-being for the service providers. Here, I'm going to be quoting from an excerpt from a participant who was training to be a psychiatrist at that point, who identifies as a cis gay man, who said, "I worked as a psychiatrist and then I worked as a physician. So that was very exhausting for me. I saw patients die in front of me every day. Every day I saw 10 patients die." So after the point, it became like, what can I do? Imagine my own dilemma at that point. I'm 25 or 26. We had 1 week of intense COVID-19 postings and then another week of psychiatry. So I had to sit through patients talking about the issues and I didn't have energy to sit through. And I think we need to understand first what our roles are during public health emergencies. This was not just this particular psychiatrist who spoke about this. This idea of a lot of psychiatrists, psychiatric nurses, clinical psychologists working inpatient, having to not only work and provide psychosocial support through their OPD and inpatient cases, but also work frontline. There were a lot of clinical psychologists who also spoke about the fact that they were also working OPD, they were doing inpatient, and then they were called to do crisis and trauma counseling for someone who's lost a family member or who's in the ICU, who's just got whose families wants to know what the status is, and who's also going through grief themselves while they're navigating their personal losses as well. So this was something which was a very recurrent thought. What are the roles of service providers during public health emergencies, and how can we care for people who are providing this support, and not just people from the community who are providing the support, but frontline workers overall? Based on these, we have a few recommendations. The first is to prioritize self-care by utilizing personal support mechanisms, including but not limited to friends, families, pets, and professional community support. What we saw, which was such a recurrent thing, and this makes me so happy, is that a lot of people at that point in the pandemic relied on support from their pets because they were isolated from their families and other support mechanisms. So having pets around was something that helped them quite a bit to connect and take care of themselves and regulate their own distress as well. Second would be to seek supervision and personal mental health support. This is something which people who are not from the mental health field will find surprising, but in India, this is not a norm to go through regular supervision, even though it is ethically required. A lot of service providers who were working online at that point, who were working inpatient, spoke about the fact that either they had no resources to seek supervision because it is, again, a very costly endeavor, or they simply had no time to go through supervision. And supervision is a space in mental health where is not only someone who is more trained or is a supervisor enters to provide support on a case that you're seeing or on how to interact with a certain intersection of mental health, but they also support your own professional journey and any distress that you are facing at that point. The third would be to understand the limitations of care provision and to utilize referral mechanisms to distribute caseload. This came up quite a bit for not just peer support providers, but also people who are working as CSO representatives, who are doing mental health and psychosocial support, where they would work for hours and hours and hours at a stretch because they had no other means to, or no other referral channel to share the caseload with. So it becomes extremely important to recognize when we as mental health providers our care stops, and what can we do when we are no longer when we no longer have the capacity to provide this level of care. For mental health institutions and other institutions providing support, we recommend creating institutional guidelines on emergency protocol. A lot of government institutions and participants who worked in government hospitals spoke about the fact that there were advisories and there were regulations that they were seeing. So there was a certain amount of clientele that they could see inpatient, they were suspending inpatient services in certain areas. However, this was not the norm for people working in private mental health spaces, in private mental health institutes, tertiary care centers, or trusts. So it becomes extremely important to have an institutional guideline on what to do in the next public health emergency or what to do during an emergency as well. This includes, but is not limited to, the recruitment of service providers. Who qualifies as a service provider? Can they increase that to peer support providers to recognize the fact they are also an integral part of the care system? To define very clearly what role division looks like, when there are psychiatrists, psychiatric nurses, clinical psychologists who are providing support, which is crisis, and also doing their own work in psychosocial support, remuneration policies. A lot of people who are training at that point, working in trust or working in hospitals, spoke about the fact that they were not getting paid for the work that they were doing. So they were sitting and taking 8 sessions a day, working inpatient, then going back and also trying to manage their own finances, their own life during the lockdown. So it becomes extremely important to clarify what remuneration policies look like and also what are the crisis management strategies that professionals can go through. Fifth, I think this is something which we all found very interesting because this was coming up very recurrently on how to create specific mental health programs for frontline workers. Who takes care of someone who's taking care of everyone else? And if we don't have those mechanisms, how are we going to establish the well-being of these care providers as well? I want you to all to just take a look at this particular quote for just a second before we move on to the next section, which is a peer support provider who is a gender fluid person who is a community-based organization representative. They worked in 5 different South Indian states and also had a pan-India emergency relief coordination. And they worked at a very senior level, making sure that they're working with funders, they're working with the community themselves, and also providing emergency relief. This is a quote from them. I'm just going to take a second to read this out, but I will also want you to just think about the pandemic and this quote. This is a person from the community that said, I was literally working for 14 hours daily. No Saturday, no Sunday. The only breaks I take are, like using the washroom and eating. I'm not even exaggerating. Sometimes I used to eat on my knees with the phone on the side when the phone battery is gone. And I would eat as I would recharge it. I was burnt out. This is coming from the pandemic where this person is from the community. They're working to make sure that community members like them, community members from their, not even from their region, but from across the country, have access to resources, have access to oxygen cylinders, emergency provision, have money for internet top-ups, rent when they've lost their livelihood. They were working for 14 hours a day and were completely burnt out by the end. How do we take care of service providers like that? How do we take care of community members like that as well? Yep, that does sound very, very exhausting. And this was not the first time where burnout was mentioned. Burnout very explicitly, something that we do when we're coding the data that we're getting and the narratives that we're getting. We'd also look for what are some recurrent words. It was not surprising to know that almost everyone described the pandemic as something which was exhausting that caused them to burn out during that time as well. Now, we spoke a lot about these 25 recommendations, and we are recommending a lot of these things. But then what do we do with these recommendations and who needs to do this work? When we did the community consultation event in Bombay on the 1st of October in Bombay, we took these recommendations and a much more exhaustive list of these and went to the community and asked, okay, who do you think the onus lies to? Where do you think the onus is placed? And a lot of people spoke about the fact that the onus can't be on mental health professionals alone or on mental health institutions alone to make sure this happens. And we completely agree. We strongly advocate for systemic change, which is only possible through collaborations at all levels. We encourage civil society organizations, state governments to liaison with mental health professionals and community members to effectively engage with these recommendations, to make sure that these recommendations are not viewed in a silo where this becomes another policy paper or white paper that is just given to a mental health professional, but they take these to heart and understand what they can do moving forward to ensure the services are not only present and available to the trans and gender diverse community, but the service providers themselves have training capacity and have the time to be able to provide these services as well. We did these interviews across the last couple of months, and the study is rooted in this year itself. Some of the challenges that we faced while doing this was the scope of community-based participatory research, right? We held this consultation event in Mumbai and could only invite community members who are from Bombay. Now, that in itself excludes an entire intersection of people who are not physically located in Bombay. This was due to financial and resource limitations that are, and we're very cognizant of the fact that this completely excludes a whole subset of people from the community. As you're seeing the webinar today, the dissemination strategy is online and in English language. This is something that we are working very hard to make sure that we mitigate moving forward, where we are going to be providing this policy brief and we're going to be providing other resources in English, but also other languages as well. In terms of the stakeholders, the participants, out of the 20 interviews, we could not include people other than one lawyer, people who provided legal aid. We could not include social workers, people who only worked in tertiary care settings, and people who worked in grassroots mental health support systems. This is something that we struggled with throughout the outreach and throughout the recruitment as well. And we're going to make sure that we address this in future projects whenever we get a chance to do so. a lot about the research and a lot about community-based participatory approach when it's done. We're all community members who are part of the research team. There's a community advisory board. But where do we go with these narratives, right? In qualitative research, something I want, like I keep emphasizing, and we all echo that, is that this is not data, this is lived experience of a lot of people. And we take these narratives and move forward. So to go from academia to advocacy, we've done a few things and we're going to be doing a few things. The first thing that we did was Sharon, who we just heard from, who's the lead researcher on this project, they presented the preliminary findings of this project at the 2024 MSF Scientific Days Conference. MSF is Medicine Sans Frontiers, which is Doctors Without Borders. They had a scientific session on addressing health inequities, which was chaired by Dr. Aksa, who's a co-investigator on this current project, where they spoke about their experiences on the research. They spoke about the community consultation event which had taken place and the preliminary findings that we had from the 18 interviews. The picture that you see in the middle is actually an illustrator, I'm forgetting the name, who made a really nice illustration of all the speakers who were on the panel that day. What we've also done, and we are very excited for this, is we got an opportunity to co-write an op-ed with two of our CAB members. I got to co-write an opinion piece on Queerbeat on moving from resilience pornography with Aritra and Tanvi, who are both community advisory members here. We wrote this over a couple of months and it was so interesting for us because when we were writing this, we were also taking in from our own experiences of being from the community, navigating the pandemic, but at the same time, rooting our experiences back in the study and seeing what are we understanding from the participants. And we wrote about the fact that there is a recurrent narrative of people asking the community members to keep bouncing back every time a disaster or every time an emergency hits, and that we need to move away from this idea of resilience being equated to almost pornography, where we are okay with walking and watching people be resilient, but we're not addressing the systemic barriers. Both the MSF presentation and the Queerbeat article are present online and are open access, and we'll be more than happy to share these with links in the future with the other dissemination strategies that we have planned. The next steps are we aim to publish the advocacy policy brief that we just presented to you in two formats. One, a plain language brief, recognizing the fact that academic language is exclusionary of a much larger community that needs to access this information, and an entirely illustrated brief as well, because we also understand that even within plain language, there are discrepancies where people with disabilities, people who do not necessarily understand the English language will not be able to access these language formats as well. These were one subset of the recommendations that we got specific to mental health professionals. We've also got a whole set of recommendations for civil society organizations, legal aid providers, funders, and also the state, which is essentially the national government and also state governments and other ministries. We're hoping to develop these into a health systems reform paper and integrate the findings to advocate for systemic change. At the same time, we recognize the importance of continuing this work and to build on the findings of this project moving forward. Someone in the chat said this is a great way to make the initiative and narrative accessible. Thanks. We're very excited. This is something that we believe in community-based participatory research, that at the end of the day, the output is not academic. It is supposed to go back to the community. And how are the best ways that we make sure that happens? We have spoken a lot about what we have done. Now it is extremely important for us to talk about what we can do moving forward. I see there's something in the chat again. Okay, Zahat, thanks. What can we do moving forward? Here is where we're going to call on all of you to see if you want to collaborate with us. Is there something that we can do together to ensure that there is advocacy for state and social health systems? Currently, through these narratives, what we understood was that HRT and HIV medication was not considered life-saving and essential medication during the pandemic. And this is something which the DGT community is strongly consuming at that point. So how can we advocate for the HRT and HIV medication to be considered life-saving and essential? How can we create transgender and gender diverse affirmative helplines or sensitize the existing helplines which exist? What can we do in terms of training and capacity building of mental health professionals, police, lawyers, relief camps, funders? What can we do to ensure that education in itself is inclusive? And how can we strengthen grassroots initiatives as well? We've spoken a lot about developing repositories and referrals in the 25 recommendations here and also in the other policy briefs that we're creating right now. Though it becomes important, how do we develop these policies and how do we develop these referral repositories moving forward? And where do we fit in here with you here as participants? So any space that you see for collaboration, do reach out to us and we would love to take that forward with you as well. All right, you've seen me speak quite a bit. And now we're going to pause for a second where we get reflections from team members, advisors, and participants. I'm going to call three people you're going to be listening to. You're going to be listening from Sharon, you're going to be listening from and you're going to be listening from Joshua first. So I'm just going to hand over to Sharon to share their experiences during this study. Over to you, Sharon.
Uh, thank you. Just a second. All right. So, I think my reflections from the project, I think I'll reflect more on the process of doing the project than, I guess, the findings themselves. But I think, yeah, one of the things, the assumptions that I had going in was like, I don't think people would be interested in the topic. And like, I think they've spoken about this endlessly. So, but I was keen to see that like, both mental health professionals and community members still are really, it's an active memory, and remembering and reflecting on what happened has like great value, and taking stock of what happened has great value. So that was one. Then the other was that there were so many different mechanisms through which community-based organizations and MHPs worked during the pandemic that, kind of have gone undocumented. So I think this was a really vital way to collate them. And how, everybody was thinking on their feet and trying to be responsive, burning out, picking things back up, asking for support, and yeah, so I mean, to see things on the provider end also was very interesting. Also very interesting to see that, of course, most of the support that was being provided was through community organizing and through community members, and largely there was a lot of state neglect. So I think that gave me that is something that resonated with me in my experience of what the pandemic was. um, Finally, one thing within the research process was the community advisory board. And I think this particular community advisory board, it's like a community advisory board is a mechanism that is a group that a lot of research studies use now to make their work participatory. But I thought that the inputs and the perspectives that we got from the community advisory board were completely invaluable and really allowed us to think about the recommendations in different ways. And definitely every meeting that we had with the members really refined the work. So I think in that way, a lot of sometimes people can view research as like, one person's endeavor or like a solitary thing that one smart person has made the research. But I think uh, just like the community organizing that happened during the pandemic, I think there was a lot of like interdependence that was happening within this research as well. So I think that was really valuable to me personally. Um, then I think the main takeaway for me for the findings of the study is that it would be a mistake to look at mental health and also to look at mental health um, as the problem of, say, as the problem of mental health care providers or like in a silo. And I think it's deeply shaped by material conditions, and the problems are very complex and need like all hands on deck kind of. So yeah, I think that would be one of the key things that we already knew that also got highlighted, is that mental health is very political, and it is about, do you have food on the table, and do you have social support, etc. So that those are some reflections from me. I'll hand it over to Hari.
Yeah.
Yeah.
Over to you, Hari.
Thanks, Sharon, and thanks, Path. I'm Hari Kirtan. You can use pronounce he, him, they, them. I have been part of this study mainly as a public health researcher, somebody who's keen on reforming our health systems to making it more just and equitable. So Path has asked me to share my reflections being part of this study. And my second point, Sharon has already said, so which was the learning or a reinforcement of the learning of the strong linkage between the social and psychological. And at all levels, I think there is a lot of need to strengthen that linkage. So I think in this study, a lot of the conversation was about how civil society organizations and mental health professionals, different kinds of mental health professionals, were working together. And I think this has to happen across all levels, secondary, tertiary care, to regional health system governance, to national level conversation between the Ministry of Social Justice and Ministry of Health and Family Welfare, for example. So that's my second point. Now, coming to my first point is more of a reflection as a public health researcher, especially um, for those public health researchers who are in our audience. I think you might resonate with this. So for me, my journey in this specific area started um, uh, because of certain conversations in 2019, 20, where a lot of people from the community spoke about challenges that they had during the pandemic. And in 2021, I had the privilege to be part of a study that what Sharon spoke about today, Transcare COVID-19 study, where we were able to document a lot of those experiences and share that. And but now I'm glad that we could take that a step forward. And unfortunately, we could do that only like almost 2 years later, 2023, we applied for funding for this particular project in 2024. So that's 3 years after that study where we could take those findings. So 2021, we were learning about the different kinds of impact of the COVID-19 pandemic on the mental health, but that there were also certain efforts that were being made, and how can we continue to do that? How can we build on that so that we can do better as a country during the next public health emergency? So this year, I think I'm so glad that we were able to do this project and clearly document, especially the competencies that a mental health professional should have. And the next thing going to be doing is to look at what should a health system be doing so that during the next public health emergency, we don't have a COVID-19 again. And so that has been a great privilege for me to be part of that journey from right from looking at the experiences in healthcare, the impact of COVID-19 pandemic, and then trying to figure out what could be the specific things that we could do as mental health professionals, health systems, that we don't have this happening again. And learning from that again, I think what I would be keen on doing and looking to all of you in the audience today is to how we can take this work forward. And that may not be this particular team; it could be any of you. In terms of, for example, we've identified these competencies. How can we, train professionals on that? Could this be part of a training program in a particular psychology course somewhere? I think that would be a great output from this project. And if there are psychologists here, there are psychology teachers here, there are public health researchers here, what could you be doing to take this work forward so that the next pandemic or the next conflict, we don't have the same thing happening? So personally, from the Sangha team as well, we are really looking to collaborate with people to take this forward, especially some conversations we've been having are to look at converting this into some kind of courses and course modules and things like that. So keen to hear from all of you. If not today, please do write to us or reach out to us later so that we can take this work forward. Thank you so much.
Thanks, Atan. That's very valuable reflections from your end. I'm going to now call upon Joshua, who's very graciously volunteered. Joshua is a peer support provider who was a participant at the study, and they are here to share their experiences of working as a peer support provider during the pandemic and also some of the challenges that they faced. Over to you, Joshua.
Hello. All right. Thank you for having me. So when I was part of this project, when I heard about the project, I was like, I'd like to be a part of it no matter what, because I really think I still do think it's something super interesting. When I was doing the interview, I guess what I thought I'd talk about was what helped and what the mechanisms and the strategies that help support the communities. And instead, what I ended up talking about, to my surprise, was more of like within the communities, maybe what are uh, the ways in which our communities themselves are structured caused maybe issues or exacerbated like the mental health issues of people in the communities. So to give context, as a peer support provider and also now a mental health provider, back then during the pandemic, a lot of my work, a lot of my support was in maybe WhatsApp groups, online groups, Discord servers, stuff like that, of people who were a lot of queer trans people who were kind of banding together. We were on call every day, constantly talking about stuff, constantly unpacking what was happening, sharing about grief, about like fear, about trauma, a lot of things. And that was kind of a lifeline for a lot of us going through the pandemic, was that constant ongoing support. uh, so the problems that emerged from that were that a lot of the support was happening informally through the communities. Peers were just showing up for each other and helping each other out. But the spaces, the ways in which they were facilitated, did not necessarily maybe promote safety, or maybe like have maybe boundaries in place to kind of allow that support to happen more safely. So a lot of times what happened was that people in power in these spaces were not great with the power that they had. And there was a lot of abuse, unfortunately, of that power that was happening. There was a lot of maybe uh, you know victimization from within the community themselves. There was a lot of like a lack of boundaries, a lot of enablement of abuse and assault and harassment. So that was, and even like for community members who really needed access to the space, sometimes, or to these spaces, needing to participate in a certain way, needing to kind of come with certain awareness or knowledge about how to even participate in spaces like these. Not a lot of kindness and empathy was shown to people who are young, who are learning. And a lot of the people there are also quite young and kind of learning and navigating a lot of these things themselves. So, what kind of I realized was the importance of having well moderated, well facilitated spaces, uh, as also integral to maybe like community well being during emergencies like this, is as much as maybe outside of counseling sessions, for example. No, wait. As much as during counseling sessions, we can offer support to participants, and we have that window where we're like, okay, as a client, I can offer you support. I think also looking beyond counseling sessions as to how we are working with our communities to build them, to support them, maybe like helping them have mechanisms in place, like maybe policies against harassment, policies against discrimination, how to handle cases of conflict in a way that is maybe looking into more restorative justice than carceral or punitive justice. Like instead of being like, okay, you're kicked out of the space, you have no access to communities, but kind of looking at different ways of exploring that. And also maybe what are maybe repercussions, accountability for people who are causing harm to each other in moments of great vulnerability. Like there were people who were maybe kicked out of home, they were maybe being housed at other queer people's places, and in those spaces they were being groomed. So there was a lot of like, you know, uh, not great stuff going down. So I realized that a lot of what I talked about is within the community, what we need to strengthen are just structures that allow us to hold each other accountable and protect each other's safety, so that the support that we offer each other doesn't come at the price of like well-being, dignity, all of these things. But yeah, that's what I wanted to share. I hope I covered what I was thinking of. But yes.
Yep, that's really, really helpful. And something
Well,
that was so drawn to me from into the work with Joshua was also that was that we were looking at harm from the lens of mental health professionals or the system that was harming the people from the community. And up until Joshua's interview, then we got to know that there was so many underlying harm and conflict that was happening within the community itself in these platforms, right, where people were going to seek support. So it became very important to also take that lens and to understand how we can strengthen the community. We're now going to move forward to advocacy and how we can build on these findings and outputs. And for that, I'm very excited to call on Aritra, who is part of the CAB, and Aritra is someone who I co-wrote the article with Tanvi with for Queerbeat. So, Aritra, over to you.
I would not want to like hog with a lot of inputs because I think that a lot has been said already. But some of the pertinent things that I wanted to highlight in this note is one that I would draw in from what Shireen said, and that we need to look at mental health from an ecological perspective and to understand what are the ecosystems where we need to intervene. I think that is something that the policy recommendations do in at least teasing out which are the areas where we need to do the interventions. I think that can be a good stepping stone for us to formulate further. And also, when we were like usually going through the findings also, because I was a part of the initial draft being talked about, what I also realized that our inability to, for instance, include grassroots stakeholders, this has also been an issue, right? Where there is a professional fraternity in their separate silo, and then there are grassroots people in their separate silo, and there is a little amount of bridge building between these spaces. And that needs to happen definitely more, because if that doesn't happen, then the kind of recommendations do not percolate to ground realities. In this context, I wanted to share that I have been working as a peer support trainer for a grassroots trans organization comprising mostly of people in informal sectors who have also incidentally, during sessions on minority stress, for instance, or dysphoria, for instance, have opened up during to the kind of challenges that they were facing during COVID. So that has been like a learning experience for me to work there while building capacity. So having this lens that the ecological understanding is sort of very important, and to understand that the intersectionality aspect of it does not get weeded out. So at every point, questioning who are the stakeholders and whether there is nuance to the stakeholders that we are considering. And of course, I would say that we have been able to identify certain categories, but the groundwork for me is also to deliver action plans. Maybe there have been talks about courses, so particular course outlines, specific objectives, and then each of us, I think, also taking individual responsibility in our own respective ecosystems to create certain ripples. If we can liaison with community organizations that we know of, that also, I think, becomes really helpful. One thing I also wanted to highlight in terms of professional training, and something that I've noticed is lacking a lot, that when it's a public health emergency, you cannot really wait to understand what is a trans person's context in which they are seeking care, what are the stressors on them, and immediately sit in a conversation with them to understand that. You need to have some prior understanding to even facilitate the conversation. That prior understanding is often lacking, which is why people feel unprepared as to what to talk about. And in my informal conversation with Parth, it has also surfaced that, there's this loading of caseload on the person who's from the community or works with this. So it becomes the sole responsibility of that particular professional to handle these cases. So if we follow that approach, then the learning really does not get distributed. So that also needs to be addressed, that it cannot be some community person's responsibility who also share a professional identity to just handle these barriers. It has to be something that has to be taken up at a professional level by respective people, so that it is a collective responsibility and does not become just the person's responsibility who is hailing from this particular space to provide care in that context. These are some of the thoughts that I wanted to share. And I'm sure that the Q&A will also enrich this discussion further. Thank you.
Thank you so much, Rita. This really helps a lot. And this is something that we've spoken about a lot, that, when we're working as mental health professionals, does the onus then come back on the community members who are also mental health professionals to just be saturated with this amount of work or this amount of caseload as well? So that is a lot of poignant points there. And in terms of my own reflections from the last 10 months, I entered this project while I was already working as a mental health professional in an OPD setting, and I was taking a few clients a day, a very significant caseload at one point. So when I entered this study, it was very important for me to also see, okay, what can we do? Where do we place the onus on? Would it be, again, mental health professionals need to be trained, or are we also looking at much systemic structural factors? So the fact that we've been able to identify these recommendations, not just for mental health professionals, but also for the state, also for CSOs, also for funders who can fund projects like these, or immediate resources in emergency relief, is really important to me. And I'm very glad that this happened. We're now going to be moving forward to the Q&A section. And this is where I will be stopping my screen for a second as well to get in with everyone who's part. Thank you so much for staying back. I know it's been a long session, but yeah, please go ahead with any questions that you have. Use the hand raising feature. We already have someone. Yep, Mukul, go ahead.
Hi everyone. I hope I'm audible. Uh, Great. Congratulations, first of all, to the team for this phenomenal piece of work. I echo Sharon's and Hari's reflections on how um, there are multiple social and material determinants of mental health, especially for queer communities at large. And which also I think is enshrined in your in the title of the project, which highlights on psychosocial support and not just mental health support. Then, and from the findings, what I see is a lot of referrals came up a lot of time, and rightly so. Uh, but I'm just curious, and I want to ask the team if they've identified certain practices or best practices, if I may call them so, where you saw effective referrals being made across systems, maybe formal health systems, legal systems, law enforcement, whatever, which not just proved that referrals work, but also kind of highlighted allyship in some sort from larger cis-het systems. Thank you.
Fantastic. I'm just going to start by answering this question, and anyone from the team who wants to hop in, please do so. But yeah, we did see that with a few participants who were providing psychosocial support from a CSO perspective. They spoke about how helpline systems and referral systems, when they started out at their own level, whether they were giving emergency relief, they were giving internet top-ups, they started building up these referral systems during the public health emergency. And we identified some ways of making that happen, which are in a much larger discussion for CSO representatives as well. But this was a very rare occurrence. These are some things which are trial and error during that part as well. For specifically a participant who provided legal psychosocial support at that point, they spoke about how there were a lot of people from the community that needed that support, and they were liaisoning with mental health professionals and CSO representatives, but that was also an individual effort that they were making with civil society organizations. So a lot of these referral systems, we're also looking at how to make sure that these take place. What are some ways? Can these be formalized in public health emergencies? Going back to what Aritra also said, that is there a way to make sure that these can exist from before? From the data and from these narratives, we haven't identified best practices on how to create these referrals, though there are some that come up from a few instances that we will be highlighting. Sharon, Hari, if you want to go ahead.
Thank you.
Yeah, I mean, if there's another question we can take. Otherwise,
Yeah.
what I just wanted to say that, yeah, I think CSOs often act as or like grassroots organizations act as some kind of aggregators where they are either by will or just because they're the only source, kind of the space where they have to coordinate between multiple stakeholders. So that was the case this time around as well. I think from your question, what I'm thinking is I think mental health professionals, peer support providers, I think are less trained in like, legal competencies and like what might be the referral networks for somebody needing, HRT, et cetera, et cetera. While they do are sometimes if you're trained in queer and trans affirmative support, you might be trained in the fact that there is a need for there is a unique stressor related to gender affirming care, etc. But often not in touch with what systems to connect people to. So I think that definitely is like an important competency for mental health providers. I think just by the structure of how sometimes mental health training is made, somehow the connections are not made. But yeah, Dr. Rupa, I think, yeah.
Yes, hi. First of all, thank you for this very informative session. The sharing of this study was very encouraging. And I would just like to, it's not a question, but I wanted to make this suggestion that we run a helpline, a mental health helpline in Pune, and also a helpline which is running for HIV/AIDS since 2005. So I would like to understand if there is a procedure, a way in which we can be part of this procedure, this study in future, because in my best understanding, our helpline, our mental health helpline, and the HIV helpline both work with biopsychosocial support, inclusive approach, and it does has gender affirmative counseling process in its way of counseling. So
Thanks, Dr. Rupa. That's fantastic. And that's something that we've made a note of as well from what you put in the chat. That's something that that came up quite a bit was that, when there are existing helplines, are they queer and trans affirmative, and how can we make them queer and trans affirmative? So we definitely look forward to reaching out to you with further ideas. We'll be sharing the policy brief with you as well to just see how that looks up in your own setting as well, and then to take this conversation forward. But thank you so much. Very glad to hear that there are initiatives like this which are already taking place.
yes, sure. Because Mr. Bindu Madhav Khire had been one of trainer right from the beginning of the helpline work, who's quite active in the gender affirmative work from Pune. So we will like to know more as
Fantastic.
yeah.
That's fantastic. Thank you so much. We'll reach out definitely. Any other questions, any other suggestions, please use this time to also give your comments on the policy. And if you think there are some things for mental health professionals that are missing out, if there is something you would like more clarity on, some other systemic social factors you think we need to include, or just your reflections on this process. I know we've been speaking for quite a bit over the last couple minutes.
Yeah, I wanted to add something if that's okay.
Yeah, definitely. Go ahead.
Something I forgot to mention was the intersectionality of other identities, like within spaces of maybe who has the power to sometimes gatekeep access to support or offer support or even like manage spaces. So I noticed that a lot of times when there was like issues of power imbalances, there was a lot of maybe siding with upper caste, upper class, Savarna Hindu sort of privilege, and not a lot of maybe invitations to people from other intersections of marginalization being opened up. So even when there was like issues of maybe accountability, issues of maybe like, interventions, the kind of people who got access to the support versus the kind of people who were sidelined were also kind of subconsciously mediated through that. There's also a lot of class issues in play in terms of access to spaces and communities that could offer support, like maybe people having to come from a certain background, like I mentioned earlier, maybe of knowing vocabulary, knowing terminology, knowing why supporting BJP is bad, for example. I mean, that's just my personal opinion, but yeah, so just like small things like these of like having to know all of these things, experience all of these things, have the certain left-leaning politics, having to maybe like, there was a lot of privilege at play in who got access to support as well. So I think that's something that I wanted to bring up, but I forgot to. But yes.
That's very helpful, and that's something that we've also seen, that certain intersections, even within the TGD community, right? Certain identities like the erasure of intersex people, the erasure of gender fluid people, arrow ace identities from support circles, and even within support circles that were being provided, there were cis gay men who occupied more space in the online support community that was there for queer and trans people. So it's definitely very helpful for us to look at the intersections within the community as well. Any other questions, any other last thoughts before we move on to the conclusion of this study? Yes, fantastic. If there are no more questions, we're going to be taking a picture. If you're comfortable with, this is already being recorded, but we're also going to just make sure our end the screenshot works out. But if you're comfortable, you can switch on your cameras and be present with us. If you're not comfortable with that, that's perfectly all right as well. We'll be just giving you all 10 seconds, 10, 15 seconds to do this. All right, fantastic. Lovely to see a lot of people there. Great. Lovely, fantastic. All right. Sharon, should I take the photo? Okay, yeah, I'll take
I'll
it.
take it. I think we
Okay, cool,
can both
cool.
take it. Okay.
Cool.
We can do a 1, 2, 3 for
Yes. Okay. 1, 2, 3. Smile, everyone. All right, we're going to do that once more because trust me, someone would have had their eyes closed, and we'll choose a photo that everyone looks nice, and don't worry. Okay, we're going to do this once more. 1, 2, 3, smile, everyone.
All right,
All right.
sick.
Fantastic. All right. Thanks. If there are no more questions, you can definitely reach out to us through other channels, through our emails, through our other spaces, and we can take this conversation forward. But now I'll be handing this with the positive time to Sharon back to close the presentation for today. Back to you, Sharon.
All right, thank you. Thank you so much. I would like to start by thanking everybody in the audience for staying till the end, even the people who didn't stay till the end. Thank you so much for joining, taking out the time on a weekday evening. We will have more outputs that are coming out soon, and we really want to think of these outputs as flexible and evolving documents, and where, somebody might be working in a hospital, somebody might be working in their own practice, and you are able to take these findings and apply them to your context as is necessary and take this sort of forward. I would like to thank the 20 participants in our study and all the community members who showed up for each other during the pandemic. I would also like to thank the attendees of our consultation in Mumbai. We had around 35 to 40 people who showed up again on a weekday and spend the whole day with us. And the consultations are generally structured in a way that's very exhausting. So thank you to them to stay and give their input. Some of them are here. Thank you so much. I would also like to extend my gratitude to Aritra, Aryan, Basena, Dr. Bala, KP, Ne, Pooja, Tanvi, Anant, Aksa, Gautam, Hari for your continuous guidance. I would like to thank Parth for their passion and for leading the interviews and the analysis for this project. I would finally like to thank the iHEAR team and Deepti and Prashant for who help us with the finances for the project. I would like to thank the funder for the project, the Gender and Public Health Emergencies Working Group. And I would finally like to thank my own friends and therapists and psychosocial support systems that have allowed me to go through this year and show up at work and do this project. So thank you. Thank you so much.
Thank you so much,
Unnati.
Sharon. Yeah, before we move to Unnati, a big shout out to Sharon as well for not only leading this project, but also for supporting all of us and our work, Sharon. Thank you so much. You're an absolute gem. All right. Unnati, you have your hand raised. Do go ahead. Please go ahead.
I'm so sorry to raise my hand
No
so late.
worries. No worries.
I just had a question. So I just wanted to understand if you guys were able to collaborate anytime with the district administration of any state, and how was their response to the initiative?
That's a very good question. When it comes to government representatives who provided psychosocial support, we only had 2 participants from one government hospital in Lucknow. That was the limit and the reach of our work with the government professionals. And that's something we're looking forward to hopefully engaging more with moving forward with the policy briefs and with the specific recommendations for the state ministries, because that's an area we've not tapped in yet. But yeah, that's definitely something that we're going to be taking forward.
Right. Thank you. Thank you so much. Yeah.
No worries.
Sir,
All right. Yeah, sorry, Praveena, go ahead.
yeah. Sir, actually, I'm from AIMS, Madurai. We people, a team of investigators, we are beginners actually. We have started our work on transgenders, whole as LGBTQ actually. So by any possibility, if currently we are involved in an ICMR project, sir. In future, by any chance, you can be a consultant or anytime you can provide guidance or we can get some guidance from you by any chance if you want something related to our project. Will it be possible, sir?
Definitely, we'll reach out to you. There are some fantastic people on this team who are part of our CAB and also from our team at iHEAR. Would love to collaborate with you. Can you put in your details on the chat so that we can reach out to you?
Sure. Thank you.
Yes, no worries.
Thank you, sir.
And for the people in the chat who missed out on some details of the findings, we will be sharing the policy brief and the advocacy brief, illustrated briefs, etc. will be made open access soon. This is the end of the year, so we're sort of everyone's working on the last end, but we're going to make sure that all of these resources are available and that we reach out to you all with the findings and the details. So don't worry about that. And the recording of this will also be made public so that it's open to view again. Fantastic. All right. Great. Thanks a ton, everyone. We're going to close for now. Thank you so much for your patience of staying back on a weekday. Thank you so much. We really appreciate it. Have a nice day, everyone. Thank you. Bye-bye.
Thank you all.